Good morning, everyone. I can't see any of you. All I see are bright lights. Thank you for coming to the session. We are going to embark on a journey about whether we really are doing client-centered practice. I'll go to the end and I'll tell you the answer is sometimes. I'm Susan Johnson Taylor. I'm an occupational therapist. I'm currently in Charleston, South Carolina, just retired, sort of. But no, I'm not. Yes, I am. But spent about 35 to 40 years with direct client contact in large seating clinics. So I've seen and worked with thousands of people across the country. We have gathered together here a very esteemed panel of experienced folks. I do want to mention what we would like to accomplish here. We want to talk about what is this goal-oriented, client-centered approach anyway, and why is it a good idea to direct ourselves toward that? How can we maintain that client-centered approach with all of the pressures that all of the different roles have coming down upon us nowadays? And we'll talk a little bit about the detail-oriented approach that we need to maintain. But before we do that, I would like everybody to introduce themselves and talk about their experience.
I'm Kieschnik. I got my ATP back in the late 1900s. I've been in the industry for 40 years plus, or who's counting. Pediatrics is my love being on the floor with 3-year-olds. And I am now working for New Motion as the ATP development manager. So I'm working with all of our new ATPs coming into the field force.
I'm Karen Roy. I am from Baton Rouge, Louisiana, and I work with Ann at New Motion. I was shot in the back when I was 19 and paralyzed, so I'm a T10 complete paraplegic. That probably led me to getting my undergrad in psychology and a master's in social work. I worked in a hospital setting for 20 years, and most of that in rehab, helping other people figure out what kind of equipment they needed and how they were going to restart their life. And I do a disability-related podcast now. I work in marketing for New Motion, and so I create resources for people, mostly wheelchair users, and yeah, that's it.
It's awesome.
Good morning. My name is Weesie Walker. I saw Weesie Griffin up there, and I was like,
But she was Weesie Griffin about 30 years ago when I worked with her, so in my defense.
And it made me realize I'm going to celebrate my 20th wedding anniversary next month. I'm the executive director of the National Registry of Rehab Technology Suppliers, better known as NARTS. In my previous lifetime, I worked as a supplier in Atlanta. I had the pleasure of working with Susan when she was at the Shepherd Center. I worked with adults and pediatrics, and I retired, and this is what retirement looks like.
Retirement in the new millennia.
Yes.
Sort of, partially. Okay, I just want to sort of get into a few things and kind of set up what we're going to be doing. We've had a number of meetings about what we're going to talk about, both in person and over Teams, which I now despise. I never want to do another Teams, Zoom, anything ever again. Of course, we will have to, but that's fine. We are very opinionated, and we have lots of experience, and we would like to bring that to you, but we would also like that to be a discussion from you as well. One of the things that occurs is we always have to keep in mind we are supposed to be doing things with our clients, not to our clients. And someplace in the conversation we'll be talking about the traditional medical model and how that evolved and how that's evolved in our world into something hopefully a lot more collaborative. I wanted to talk a little bit about a historical perspective because most of us are historical. At the risk of sort of like, when I was a kid, this is what we did. But the historical perspective was when most of us started in around 1979, 1980, there wasn't any stuff. Everything was built by hand. And I don't say that to say, oh, we worked really hard and everything was built by hand. But what that made us do as therapists and technicians and suppliers was we had to pay super close attention to our client. We had to get our hands on them just like we're supposed to do and really understand their life, because now I have to go work with maybe a rehab engineer, technician, supplier, and build what the client wanted and needed. So as it's been our observation, as more and more stuff and technology comes on the market, sometimes we get a little bit over-reliant on the technology and don't bring ourselves back to the fact that, you know, we have these two hands and this brain and can have conversations with our client. Interesting sidebar to that, I have worked with a number of OT capstone students on their capstone projects, and the last student that I worked with came to me with her goals, which all revolved around equipment. I want to understand the equipment and how it's used and how it's made. It's like, time out. You're an occupational therapist. While you do need to understand the equipment, what you need to understand by the end of this capstone is how to evaluate a human. Okay? So we sort of redid her goals around her role. I want to very briefly, before we get into some questions, I want to very briefly mention research around outcomes, and this was interesting to me. My last job was with a large US-based supplier, and I initiated and ran an outcomes program using the assistive technology outcome measure for a couple of years. When you just look at the results, and I worked with Steven Spriegel from Georgia Tech because he's the engineering brain and can do all of the data analysis that is not in my wheelhouse. But when you looked at the data, when you looked at the objective results, they looked really good. Like, things improved. Wow, look, they had pressure injuries before they had intervention, and they don't have pressure injuries after the intervention, or now they feel a lot more safe transferring, et cetera, et cetera. When my colleague who was doing all the follow-up calls, who is a physical therapist, would call people, they would have paragraphs of comments, and the comments didn't necessarily match the glowing results that we were getting. I'm sure that everything was better for them, but then they also had issues. Let me give you one example before we move on. One example was, you know, I've been using a K5 manual wheelchair for about 25 years. Never had a problem with it. I can't really move my new wheelchair. It feels heavy. Now, in, you know, our OT and supplier brain, you're thinking, it feels heavy. Was it adjusted correctly? So all of that represents something that didn't quite gel well, I think, at the evaluation or at the fitting and training. Okay, so opening up those conversations and listening, which we're going to talk about in just a minute, is so important. I'm not going to go over roles now and who sees the client, because we have roles right here, and they're going to be talking about their own roles in the process, and about how it's appropriate, how appropriate conversations are so very necessary, which is the difference between, that feels good, doesn't it? And tell me how it feels. Okay? So we're going to start with Karen. Karen, you are in the unique position of being a consumer as well as a professional in this field. So historically, the different experiences that, can you outline some of the different experiences that you have had as a consumer, and then you can talk about your professional role next in the wheelchair and seating process.
Yes, I can. So having my first wheelchair in 1987, it was boxy. It had swing away footrest. It was a folding frame, and I guess for that period of time it was fine. I look at myself in it now and I feel like you can't see me. It's all wheelchair. But I wasn't really strong being a female, and so swing away footrests at the time were functional. I could get close to the tub because I transfer into the tub, and then I guess a little bit down the line, I didn't feel stable in it though. I started crossing my legs pretty early on. I didn't really know why, other than I thought it was cute and I wear dresses. So, but there was a lot more to it that a therapist named Susan Johnson Taylor helped me figure out years down the road, and it was that I didn't have a good center of gravity, and I felt really unstable in the chair. And crossing my legs helped me to have a better center of gravity. And my pelvis is very flexible, so in that position, I'm a lot more fixed and I'm a lot more stable. But I had no idea really what the function was about leg crossing. You fast forward to getting talked into, and as all of you probably know, change is hard for a wheelchair user. Once you get fit with that really awful chair, you just want to keep repeating it over and over again. And so I think that it's a collaboration. I'm going to get into the part where I think that you need to know a lot about the person's life before you configure a chair. But I didn't know what that I had a right-sided obliquity. I didn't know that if I didn't sit more midline and start uncrossing my legs, I'm going to end up with skeletal deformity. So those are all pieces of information that I'm gleaming from the clinicians, the ATPs, and the therapists at each wheelchair evaluation. But once I had switched to a rigid frame chair with no swing away footrests, and it's tough because I'm this much far away from the tub, right? So my therapist and my ATP need to know, how do I transfer into the tub? I don't use a shower bench. I don't use a roll-in shower, right? So, how far can I get to the surface that I'm transferring to? What kind of vehicle do I drive? I had an experience with one of my ATPs where I think it was Tylite came out with a new dual-tubed frame, and it was supposed to be lighter, which would be great for my shoulders. But we didn't practice getting it in and out of my vehicle, and I struggled with that chair for months before I basically asked them to take it back. And I felt really bad about it, but I was struggling for a very long time because I knew there was muscle memory happening from the old way of transferring, so I tried to fight that. And I'll say this, even down to the type of shoes that they wear. So I hope that you're not trying to do your wheelchair evaluation in just a 45-minute session, and I hope that you know a lot more about their life before and after, and if it takes more time, please take the time, because it's spend the time up front or spend the time on the back end, and I would much prefer getting it right up front. And I think that having worked in rehab for off and on for 20 years, people coming back later with issues is just going to be a lot more costly. And I think, so knowing, if you're at the home eval, check out the vehicle. I hope you're looking at the bathroom and how they transfer. And if you can't get that, and I understand the time constraints of seeing the person and documenting, but if it takes more than one session, I would say that you should try to get it. Because we want to feel heard. You need to know about our lives. Do we travel? What are our hobbies? What are our goals?
Yeah, I think we talked a lot about the amount of time, because and I hate looking at, these are clients who need CRT, as if they're all the same. Okay, we see people on a spectrum, just the rest of us are all on a spectrum between, pretty straightforward and very, very complex and difficult. So one person may take 45 minutes, the next person may take an hour times 3 days, who knows? But to Karen's point, you have two choices. You can try and get it right on the front end, and there's no such thing as 100%. We all make mistakes, and some of us, lots of them, eventually learn. Or you can do it afterwards, when people are going out to the home or they're coming back to clinic multiple times, trying to figure out what happened in the first place, when perhaps I should have paid more attention during the eval or during the fitting. Does anybody else have any comments about that?
I think Karen obviously has an important viewpoint, but I also think as a supplier, you have to understand, like Susan said, every person is a little bit different, right? And we talk about that a lot, but I think it's easy to fall into the, I've worked with someone with this diagnosis before, and I already know what they probably need. And you really need to start from scratch on each person, because if you don't, you're going to be fixing that problem down the road.
I'll talk a little bit about the time, and that was going to be part of my intro, was I hear a lot about, I only have 45 minutes. So I would challenge each of you, if that is indeed the scenario you are working in, you have to identify what's a priority. Everybody has things they have to get done. The clinician has to have things for documentation, and so does the supplier. And I think you have to figure out what's important. So instead of having your nose in your laptop or your tablet documenting the whole time, looking at your client, looking at your patient, and understanding who they are, and knowing that in that 45 minutes, there are things that are very important. Knowing who they are, what their life is. We used to call it 1,001 questions. There's not one question you cannot not ask. The other thing is then to find out MAT assessment, range of motion, we need all those clinical findings. And if you, as the supplier, if you cannot complete all that paperwork, that just has to be done afterwards or at some other time, because you only have that 45 minutes with your client in front of you. And if you don't observe how Karen transferred out of her chair onto the mat, or to, if you're in the home environment, to the sofa, you've missed what she does with her legs and her body movements, and what's safe and what Unique can help with. You miss those things if you don't observe. And so we really talk a lot about using your senses, observing, listening, feeling, getting your hands on. So things have changed in our world. There's a lot of technology. We have remote this, remote that. Now somebody's going to write all of our paperwork for us. But I think there's some things, some old tribal knowledge that never goes away. And those are the basics that we try to pass on to this new generation of ATPs. And for those of you who have been doing it for a while, to kind of hit yourself a little bit and go, gosh, I've gotten a little bit slack on the things that I used to do that was really important. I've got caught up in this whole time thing. And as Weesie said, if you've got to go back, what's more important? To have satisfaction on the end? Your delivery, you go in, maybe you tweak a footrest and you sign some paperwork, and everybody's like, this is the best. Because at the front end, you spec'd out center of gravity, you spec'd out all of those things. You knew what the angles were. Nobody had to guess or deliver it who wasn't at your eval. So I think there's some basic things that we know we've just kind of gotten away from.
So, thank you. Weesie, we have had loads of conversations about what we call the team approach and the client-centered approach, and how that has morphed over the years. For example, it is not that unusual, at least in the United States, to have the supplier see the person, and then the therapist sees the person, and then perhaps neither one of them are involved with the fitting. It happens. It's out there. Unfortunately, it happens, which makes continuity of care a little challenging. As head of an international organization, what have been your observations about how that's morphed?
One of the functions of NARTS is a complaint resolution process. So people, they may not be filing an official complaint, but they'll call and relate a situation to me. And 99% of the time, it revolves around the fact that maybe the chair fitting wasn't done properly. And when you dig into that, you find out, like Susan said, that there's a term people use, seating tech takes the chair out and does the fitting. And there's no problem with that if the supplier, the CRTS supplier, knows the capabilities of that technician, but it's on their shoulders. They're ultimately, the buck stops there. And so, I really, and part of me is like, I thought that was really the best part of the job. I love seeing how the technology worked for that person, and that I was able to spec out something and it went together, and the person was satisfied. Now, were they all satisfied initially? No, certainly not. But that then that became a learning opportunity. So and I understand, I've been out of the field 10 years. A lot has changed in that time. I know that the providers need to get the equipment out the door. Maybe they're running out close to the expiration of the authorization date, all sorts of factors that come into it. But I think the primary focus for the professional supplier who's doing the evaluation is to see how that equipment works firsthand with that person. And it also worries me that, today, in today's world, there are no standards for the technician who's fitting that chair, right? So that's a slippery slope.
It's not.
To say that I deem this person qualified. Now, having said that, I worked with an awesome technician for most of my career. We worked together. And so, I knew exactly what he would be very competent at delivering and fitting to a client. And recently, I've had experience to observe seating clinics for this course that we're putting together for photography. And I hear these people coming in to clinic and finding out that, well, the technician delivered it, and there's just minor adjustments that need to be made, but it required that person to make another appointment to come back to clinic because they didn't understand, oh, well, it's just the way the laterals are adjusted, for instance, or, whatever, the arm support. So again, if you don't do it on the front end, you're going to spend more time on the back end. And not only that, but it's the person and their experience of being able to use this wonderful technology the way it was designed.
Speaking of wonderful technology, have you worked with people who have been able to incorporate telehealth either as a major means of doing an eval or as an adjunct to doing an eval or fitting?
Well, one piece of feedback I got from a clinician was she said it was wonderful to be able to see people in their home environment, like Karen was talking. And I think telehealth certainly has its place, but and I'm old school, as you can tell, but I think you have to be able to put your hands on that person and know that Karen's going to want to cross her legs, or whatever it is, because each person's different, and I don't think you can gather that through telehealth. My personal opinion.
Well, and we can get the audience's opinion later, absolutely. Okay. I'm going to pivot just a tiny bit because one of the things that we have spoken about a lot is communication. I mean, as a clinical therapist in very busy clinics, it's one person after the other, after the other, after the other, so you really have to hone your skills to be paying attention to verbal and nonverbal things. So, for example, if, let's say a husband and wife are there, the wife is being seen for a new wheelchair, you're speaking with the wife, all these questions, and the husband's in the corner looking at you like, and so, Mr. So-and-so, please be involved. Do you have some thoughts about this? To Ann's point about, this is what a lot of our clients see, the keyboard. Is that okay? Good, okay. Can you raise your arms for me? Wonderful. Okay, can you transfer yourself? Great. What we miss is this. And we've often talked about if there's one thing that I can do in a seating eval, it's the client out of the chair, on the mat, or on whatever surface I happen to have, if I happen to be in the home or something like that, feeling, touching, looking, asking, and then paying attention to those nonverbal things. One thing you notice the longer that you're in this field is a lot of the clients that we've been working with for a long time almost appears they're like beaten down by the medical system. So they're really apt to agree with what, oh yeah, that sounds great. Sure, fine. Whatever you think is best, you're the expert. Absolutely. I know stuff and I know people. I don't know you. You know you. So could each of you comment, please, a little bit on how you have incorporated that into your practices, and especially for Anne, how you incorporate that into teaching upcoming suppliers?
Partnership, I think, is one of the big P's in my list, is partnering with the clinician and the family. I worked with peds, right? So in the room, I've got mom, the therapist, maybe grandma, maybe the babysitter, the sibling, and the dog. Everybody is all in my lap, and we're all working together. So communication was critical to making sure everyone was educated about the goals. What do you want? What do you need? What does this need to do for you? This is what we have found from working with your child, the position, the postural goals. This is the equipment that we think can meet that. Will it fit in your car? Do you like it, or will you abandon it? I mean, those are things that this partnership and communication, this is part of your success. And I really talk to the new ATPs, whether they're coming from the clinical side to the supplier side, or as someone internal like a seating tech who's working their way up into becoming an ATP. Communication is key. They may not like the message or the answer. It may be, no, you can't have that, or that's not covered by your funding source. But I don't think there's anyone in this room who doesn't want to know what it is. Just tell me. I don't like it, but we can talk about it. Or I can look for other alternatives to maybe fund it. But we make assumptions. Oh, my mother, for example, Medicare won't cover all of that. I didn't care. If this is what was appropriate for her, we would find resources. But give me the option. And that's down to communicating with all the people, the stakeholders, so to speak, within that eval. Don't make assumptions. You cannot ask enough questions.
Yeah, I think, is it okay? Establishing the relationship. So as a social worker, that's what we learned in grad school right away, is I better know that you care about me. I need eye contact. I need you to ask questions about my life, because if it becomes a really important relationship to a wheelchair user, the people who are creating the device that gives you mobility and allows you to do things with your family and work and, just live your life. So that can't be stressed enough, that I hope you are making good eye contact, and I hope they know that you care, because if not, and this is medical professionals all over. I recently had cancer, and I was at MD Anderson, and the doctor could not have cared less about me. So he was at the best place, right? I thought I was in the best place. But yeah, I need to know you care. And then a point earlier, like even if it's not the whole chair and it's just a cushion, I'd had people suggest new cushions. I've never had a wound, so I've always used gel with a foam. But I realized like shortly after that, when we changed my cushion to a lower profile, with something that was more squishy, like a honeycomb that sunk, I wasn't unable to get into my car, right? So. Because I used that foam, and that little inch or inch and a half made the difference between the pain in my shoulders. And that's another good question to ask, is, obviously you're doing a MAT eval, but where do you hurt? What hurts, and what can we possibly make better? We're sitting in these things 12 hours a day sometimes, so.
This is a shameless plug. NARTS did a keynote webinar for this year. It was a panel just like that, but it was parents of children, and it wasn't scripted. They didn't talk. We joined the Zoom meeting about 30 minutes early, and they didn't know each other. And I wish I had recorded the pre-part, because they were all saying the very same thing. And so imagine, as a parent with a child who has a disability, that's a tremendous amount of responsibility for that child. And one of the mothers related having a very bad experience with a supplier, and not an arts registrant, and then meeting a supplier who took the time to know the family, understand what their goals were, and help them make the right choices for the equipment for their child. And I can't say this enough. It's not just a transaction, it's a relationship. And I'll quote Jerry Dickerson because, stand up
dear,
here now.
Good heavens.
But he always says the therapist is on a date with that person, but the supplier is going to be married to that person. And think about it. And, and that's the truth. And what they appreciated the most was having a clear line of communication. And in today's world of funding and all the funky things that go on, they just want to know, where are you in the process? Is there something I can help with? And of all the people that I talk to, that is always number one, is just let me know what's going on. Send me an email, have somebody call me or whatever. And but I get it. We're under pressure. We have to do more with less, it seems, every day, and you're just on this treadmill. But at the end of the day, that's what people want. That's what they deserve, and that's how you can be most successful in getting good outcomes for your clients.
And Weesie, don't you think one of the worst things that can happen is if a family looks at you and go, no one ever told me that before?
Yes.
It's terrible.
We have failed in that case.
It's terrible. I never knew I had that. What?
Yeah.
Those
Okay.
armrests come off?
Yeah, those armrests, oh,
have
look,
to
they go up
charge
and
the
down.
batteries.
My God, you've had the chair for 5 years. As the clinician on the panel, I'm going to pivot just a tiny bit into communication with your client. We all know that we need to pay attention, ask good questions, and then listen to the answers. But there's another aspect to that I think particularly younger therapists may not feel as comfortable with. So Karen comes into my clinic. I just want the same chair I've always had. Yeah, I've been doing the same thing for 30 years. That's great. That's fine. Well, first of all, there's no such thing as the exact same chair that you have, but you can get close. And that's fine. But it's my professional responsibility to perform the MAT-eval, to let her know what the latest things are and maybe research on aging with a disability, provide her that information, maybe some suggestions, with the caveat that I am providing this as the clinical professional. I am not telling you what to do. I'm simply providing you information. The final decision is yours. I think a lot of us take for granted that our clients just maybe know that, but many of them don't. The final decision is yours, but this is my professional responsibility to provide you with this information. I have experience with lots of different people. I keep up with the research. Let me tell you about this. Sometimes it results in equipment that might be a little different, that it needs to be tried in the home or the car, and sometimes it doesn't. But that has to be opened up, and the client always has to know it's their final decision. Because I don't live in their body and I don't live their life. Okay.
Can I add one more thing?
Of course you can.
Another story related to me by a father, and his daughter got a power chair with power seat functions, and they were out somewhere and they saw somebody in a similar type of chair, and they started talking to them, and he said all of a sudden the guy raised his seat up to, grab something, and he went, well, my daughter's chair doesn't do that. And he was like, oh, well, this is called seat elevation. So he called his supplier, and he said, why doesn't my daughter have seat elevation? I didn't even know that existed. And can you guess what the supplier's answer was? And he said, what do you mean it's not funded? He said, I have a checkbook He said, how could you not let me know that was available and make that decision that I wouldn't pay for it? And I know all of you have seen these situations. So it is part of the standard practice that you show that person all the appropriate options that are out there, and it should not be driven by what you think insurance will cover. That you're taking that choice away from your client.
Yeah, 100%.
I thought they had a really interesting, or somebody, I don't remember who, sorry, had a very interesting statement in the plenary yesterday about outcomes and competence. And she was talking about how when we look at our field, we have people who are consciously incompetent and unconsciously incompetent. So people who know that they don't know stuff and seek out information, and people who think that they know stuff and don't seek out information. I think it's super important for us to be to avail ourselves of all the information that we can in our spare time. But it's very, very important. What are your thoughts on that?
Well, there are two things that kind of, it goes back to when Susan did that. I first started working for New Motion and had my, the MAT eval done. I think before that, she was looking at me sitting in the chair and I was leaning to the right. So she put me in midline, she, made me sit centered. And she took pictures of me when I was sitting crooked. I was smiling and she put me in midline and I felt so weird and off balance, but I was in midline. So
her stated goal was, I need to be able to sit up straighter. In the back of my head, I was thinking, this will not work. However, that's her stated goal.
yeah.
So
we got it back. We got it.
We just did hands-on, and
Yeah.
her face went from to.
Yeah.
Yeah.
It didn't feel good, but then,
Not feel good.
we can get it back. That's adjustable, right? So we can start off slowly and then push me more to midline gradually so that I don't feel like I'm going to fall. I don't feel so awkward. But if you don't, I didn't know I wasn't sitting midline. I don't look at myself like that. And she's like, you have a right-sided obliquity. And I'm like, okay, well, overfilling the cushion on the right and new back that we could, because I understand abandoning equipment that customers, clients don't like change. But if there's a way to make the change more gradual and then still meet the goal of avoiding serious injury or skeletal deformity down the road, I'm down for that. I know not everyone is as open to those things, but I think that if it's done in the right way, you can gently guide.
No, but my incorrect response would have been, we're not trying that. That's ridiculous. That's not going to work.
Yeah.
Or even worse, I know better. This is exactly what you need. And that's what we're going to do.
And my response would be, I've been in a chair for 30 whatever years, and I feel like I know more than you do.
I feel like you do.
Therefore, the partnership, not.
Did you have something about that?
About.
I don't know.
I forgot the question too, to be honest.
Anyway.
Well, I think it
fine.
goes back again to a supplier thinking that automatically they know what to do or what will work best for that person. Or I saw this new chair, got in-serviced on this new chair. There's more of a thought process that has to go into it. And Karen is a great example of thinking this is really straightforward. She needs a good lightweight chair and a cushion and a back, but it's not that straightforward, is it?
No.
No pun intended.
I'm struggling with it. Every time I'm around a bunch of clinicians and seating professionals, I'm like, I know they're judging me right now. That I'm sitting crooked and I'm leaning to the right, my legs are crossed. But I was kind of analyzing that with people here, which is what I love about these events. And I was like, well, I used to wear a pair of boots that had a heel, so we had this open foot plate so that the heel of the boot could go in the back hole of the foot plate, right? Well, so it's all measured for me to have shoes on of a certain type. But when I don't have that type of shoe on, things don't really work the same. Or if I'm in the house and I only have socks on, And then I end up perpetuating a problem because we kind of adjusted for one issue and one pair of shoes. So, yeah. And after this conference, I'm like, I need to get a plate for the top that's solid, that has a non-skid surface on it, so that that I can go barefoot and still have my feet touch properly or stick to the foot plate. I mean, it doesn't sound like a big deal, but it's a big deal to me.
It's a big deal. It's a big deal. So the last thing that we're going to talk about before we open it up for not so much questions, but comments, is, I just went right out of my brain. What, are you like rubbing off on me?
Yes.
Anyway. Oh, I know what it
I
is.
haven't had
Jesus
enough coffee
God.
yet. That's not.
Anyway, so that's terrible. The last thing we're going to talk about is the point of creating realistic expectations, which I know for a fact that I did not do when I was a much younger therapist, but you know, finally got into talking about what's realistic and why, and demonstrating things, but making sure that that's part of the evaluation. What are your expectations? What's realistic and what's just not realistic? Okay. So let me give you an example of unrealistic. I would like to sit up perfectly straight in my chair, but I don't want supports. Okay, and dozens and dozens of times, well, I can't support you without support, so let's talk about this. But I would not want that client to leave clinic thinking, I'm going to sit up straight and I don't even need supports. What do you think about that?
Well, you know, we talked about in our presentation on repair practice, being able to give the client written information on maintaining the chair, how to maintain the chair. That's just one thing. And I would say, again, the knowing what's available to you, but also saying, you know, this, we're pretty sure your insurance will cover, but, you know, this might be more challenging to get funding for or whatever. But as a supplier today, I realize that it's hard to tell somebody how long it's going to take, because we have all these extraordinary issues with supply chain and things like that, longer shipping times, for instance. But to be able to lay out for that client the realistic service expectation from you as a provider, how that happens, what are their responsibilities, you know, and just knowing that, you know, that you're going to be in communication with that person. And how do you want to communicate with that person? Do you want to give them your cell phone number? I mean, I bet a lot of you give your clients your cell phone number, and maybe some you don't. You know, you have an assumed identity with some of your clients, maybe, I don't know. But that's, you know, again, it's not a transaction, it's a relationship. So think of it in those terms of how you would want to be treated and how you expect them to treat you.
Susan, I'd like to jump in too. I think what realistic expectations is, we're kind of past the time where we can go, oh, I really want a cup holder. Just throw it into the order and we'll see if insurance doesn't see it and it won't cause a problem. We know with some funders, they deny one thing, they will deny or pin the entire chair. So I think the realistic expectations also come into that, again, communication, partnership, trust, relationship building of, we know your funding source does not cover this item. So if we put it on your chair, it's going to delay it or perhaps deny it. So I think those who are still asking for not using the communication available, the information that's being presented, again, we don't always like the answer, but it is the reality. And so working together that you are creating realistic expectations of what is going to be covered, what isn't. But if you know something for sure is not, we have a funder in Texas that does not pay for whether you call it an upper extremity support or a lap tray. They just do not cover it. So we have to go to a different source and funding to get that component added to their system, but it's not on their initial order because then it would delay it or deny it. And we're pending for something that we know is going to be denied. Again, we don't always like the message, but realistically knowing what it is and working together to get the end results for our clients is what we're all about. And time is the other, I mean, we kind of have the same recurring themes. It takes longer when things are denied. Clients want their chairs when they need it, but they still want it right. And they may say, Karen may say, Ann, I don't care. I'm going to fight it. I'm going to fight my funding source. Then I have partnered with her. I know that's going to be the case, and she's not frustrated because the expectation is she's going to get her chair next week because I saw her last Tuesday. She knows it may be 6 months because we're going to fight over a component that she thinks is medically and just environmental, her goals. It meets what she needs, and she's willing to help in that battle. So I think, again, it comes to some really basic things that we forget. We make it very complex, but I think if we communicate and work with each other, it's still a lot of work. I'm not going to say it's not, but.
I want to add to that too, that, and it took me a while to figure this out, but when you're letting that person know the challenges and issues with, getting things covered, you might create an advocate.
Yes.
And I believe that there could be 10,000 of us, but one person who uses CRT, their voice is so much more powerful. And if you can inspire that person to be an advocate, you've done an amazing thing. And let me tell you something, the time is now to get these people going on fighting for, what should be a no-brainer at all. Yeah. And I talked to a lady recently who was waiting on a new battery charger. So she said, I've been laying in bed for almost 3 weeks. And I said, well, have you called your insurance company? And she said, no, why would I do that? And I said, well, because you're their customer and the provider is, submitting a prior auth, I guess, for whatever parts she needed. But I said, you need to call and talk to somebody there. And I think you're going to get farther faster than relying on the provider to do it. And I guess what stunned me is that was, I should call them, so let's do a better job of waking people up, it just, okay.
Yeah, when I first got shot, I saw in rehab, Mississippi Methodist, there was an FES bike and there was standing equipment, RGO grip braces, and there were power standing chairs, even though I was in a manual. And I was like, I want all of that. And they're like, no. And I'm like, oh, I don't know. No, that's not happening. And my parents fought for me. I've been fighting for what I needed my whole life. And as a result, never had a wound or fracture, contracture in 35 years of being paralyzed. But yeah, not teach them to advocate with their getting documentation. I write things for NewMotion all the time, and a lot of it is advocacy related. I had the honor of being Consumer Advocate of the Year a year ago. But yeah, oh no. But I tell people that all the time. I'm like, as the supplier, we can call and ask for the paperwork. Call them yourselves. Tell them you are furious that you don't have your piece of equipment yet, or you can't get repaired. You have to teach the customer to fight for themselves on a big level for reimbursement, right? They're all complaining. I can't get titanium and carbon fiber anymore. Like that is going to preserve my shoulders, and I know. No, I won't say that, but they don't know. So get them involved in the fight, and then introduce them to NARTS and to United Spinal Association and to all of those advocacy organizations. And yeah, we need more. It's a lonely place to be sometimes, feeling like we need more consumer advocates.
Absolutely.
Absolutely. Anything else before we open up the floor?
I have one more thing, and I want to talk about the difference between hearing and listening. So we've talked about communication, and sometimes we hear, that's kind of the passive of hearing sound, but listening is really is an intentional thing. And so what I really work with our new ATPs is to listen with intention. You know, you can fully listen and deeply listen, but there's that critical listening as well when Karen says, I really want to sit up straight. And so critically, your mind is zooming through a whole different options of how do I demonstrate to her? How do I trial it? How do I give her the education or the experience to accept it or not? And so I think be careful that we say, oh, I was there. I heard everything she said. But did you listen? Did you listen to the message and to what the person was trying to impart to you? And so we get busy. I know it's time, pressures, metrics, blah, blah, blah. But again, it's all about the client and client focus. And if we keep that paramount, I think your success in your evaluations and your outcomes will be far better.
Because we can solve it on the front end or the other end, but it's got to be solved.
Yeah.
Okay. Now, this is not a shy group. I see some of you out there. I would love to hear, and some of you actually were sitting in the lobby with us yesterday while we were discussing all this and had some great things to say. So there are microphones here and here if people have questions, comments, or things that they'd like to add. We tried to leave, a good 8 to 10 minutes.
Yeah, tell us.
Tell us what your experiences are
Yeah.
and
Or what-
what your pinch points are.
Yeah, your
and
pinch
how you've
points.
solved it. Really?
None.
Thank you. Thank you. Oh, see,
Okay,
okay.
thanks, Lois.
And as I said, this is not an audience of shy people.
All right, now they're lining up.
Here we go.
Okay.
Can you hear me?
Somebody had to do it.
Yeah.
All right, I'll just make a couple comments. I think this was a fantastic session. I'd even love to see it even go international at some point. American accent, living in Australia under a different insurance scheme, a national disability insurance scheme, and the whole framework is built on the client in their environment with their goals. And yes, there are funding challenges. There's still consistency of coverage, but that underlying goal really does drive everything that we do. So I do find myself lucky. I've worked in this industry, in this country for a long time, but it is interesting to look at that. The one thing I thought about, Susan, and you and I have talked about these subjects before, but sometimes there becomes some medical speak in the middle of the event that's happening. And I often just turn to the client and say, hey, I just want you to know, we're going to talk a little gobbledygook for a minute. Right public obliquity, I think we're going to have to do this, we're going to do this. But I always say something to prep the client. You might hear some things that terminology that isn't familiar. I don't want you to feel excluded, but we're just going to problem solve for a minute and say, and they're okay because they now understand you're working collectively for them, with them, but not excluding them from the conversation.
That's an excellent point because none of us would put up with that from our physician.
Yeah. My other is just a very quick follow-up to Weesie's comment, because I literally did have a client who had a woman who had Marfan syndrome and was non-ambulatory and couldn't go back to work without the wheelchair. And it turns out she worked on the second floor of the insurance company until somebody actually carried the approval upstairs to the top floor. They said, if you want her to come back to work, you're kind of going to have to approve this. But, and then she became an advocate, though, within that realm. And I think that point was very well made. So thank you so much for this morning.
Shy, quiet little Lauren.
Yep.
I think the other thing that I work real hard with my suppliers to do in my clinic is to ask the clients what they like, what they dislike about their chair. I'm constantly surprised at how shocked they are that somebody's asked them that. Oh, I don't know. I mean, my kid went to school with a blue chair and came home the last time with a red chair, and nobody asked us questions. And, that sends major chills still down my spine that still does occasionally happen, except for the phone call they got where someone asked them what their favorite color was, so that's why they've got a red chair. But it's really empowering somebody to ask them, what do you like and what do you dislike? There's certain things that I like and dislike on chairs, but it's not my chair. And I do point out that to them a lot is, I like this, but if this works for you, and it's not doing anything bad to you, we'll keep that. But it brings them into the process more by saying, what's your opinion on all of this, in a way that, like I say, people are shocked at constantly, that, I'm allowed to say, oh, I never liked this footplate. Oh, I never liked this. Okay, well, I've got other options for you, so it really engages them more by asking what do you like, what do you don't like?
If I could add to that, Lauren, I have one lady, it almost brings tears to my eyes. Seriously, she didn't know she had a bad chair. She didn't know it. And she used it for 5 years, you got to use it for 5 years. And she thought it was her disability that was preventing her from being able to sit use the chair more than a few hours at a time. She said, I quit my job, I quit going out with friends, and I just thought, and then she said, I went to a seating clinic, got evaluation, and a chair, she was in a manual chair, and it was fit correctly to her. And can you even imagine putting up with something for 5 years, and then you find out it's not my disability, it's this piece of crap that I was provided, but she didn't know. And we can't lose sight of the fact that your client may not realize this really isn't the best solution for me. They accept it as it is. And that broke my heart, it truly. So I guess we could say the good news is now she has a good chair. She's gone back to work. She's living her life, and so it had a happy ending. But it took 5 years to get there.
Faith?
I just want to comment on the part of someone gets their wheelchair and they come back and they say, I never knew how to use this. So I had a person that got the chair delivered. We did everything. The supplier went back out, did all the training, and then because of COVID, they couldn't come right back, so they came back like a year later. And we are showing them something. They said, I didn't know this could happen. I didn't know how to use this. So the overwhelming portion of when you're getting that new equipment, that you're trying to get them to understand everything, and they don't remember. And it's not because you didn't do your job, it's because they couldn't retain all that information of what you were trying to impart, and to be able to add in, are you able to do A, B, and C throughout, a time period, and make sure they come back to go over those things that they just didn't remember it because there were 10 million other things.
And what a best practice, right? To be able to know it's not a watershed of information. Nobody leaves. You get the new cars. All you need to figure out is how to turn it on, because everything has all these buttons now. So I think we need to be cognizant of that. And do you need written information? Do you need a follow-up call? We do what we do because we've always done it sometimes, and we go, oh, it's just too much information at one time. But so let's learn, right? It's like, so maybe we need to figure out how to do that delivery process better over a period of time.
We have about a minute left, so another couple of questions, and then we'll get the code. Go ahead.
I'm just interested, one of the frustrations working in New Zealand is when we do the funding application, it works on a deficit model. So we've had a conversation with somebody, we've heard about their life and all the things that they're actually celebrating and able to participate in. But when we do the funding application, we have to highlight all the things that are not going well.
I'll say
We
forgive you.
Yeah, I wondered if it's the same here.
It is. We
it
concentrate a lot on impairments and not so much on independence.
Correct.
Yeah, It's unpleasant to read. We usually don't have to read it, but we understand that that's the only way to get our devices funded. So we know that you think we're awesome, but it sounds like we're awful. So.
I just wanted to quickly add on the advocacy piece. We definitely need many more consumer advocates. That's actually how I've met Karen through my advocacy work. That actually, as clinicians and suppliers, we can't ask our patients to be, I mean, we're already advocating, but to go to advocacy events, to go to local things and speak with your representatives. I oftentimes in my thing, I'll be like, well, here's a seat elevator, that's not covered, but just so you know, like I've written comments on why it needs to be covered, and I've gone and spoken with my congressmen and the senators, and that gives, as a clinician, they're like, oh, you do that, and I was like, yeah, I can send you stuff to do it too, but I think it's just as people who, like, it gives me, like, credibility if I can say, hey, I'm fighting for this too, but I need you to do a little work on it as well.
Yes.
Thank you for that.
So-
Yeah.
Thank you.
That's part of the relationship.